Thank you, Margaret. I'll start with my disclosures. So I would like to start my presentation today with a few key learnings about SARS-CoV-2 and people with HIV. What we have learned through recent publications is that there is now evidence for an increased risk of C19 diagnosis and hospitalization among people with HIV. We have also learned that the clinical features of C19 are generally the same as in people without HIV. However, we have also learned that after adjusting for age, people with HIV who are hospitalized with C19 have an increased risk of mortality. And this is especially true for people below the age of 60 in terms of difference between people with and people without HIV. We have also understood or started to understand that there is a correlation between the risk of severe C19 and a low current or nadir CD4 cell count and or lack of virological suppression. But we certainly need more data to really understand these relationships. In addition, among people with HIV, alongside well-known comorbidities that increase the risk of severe C19, we have identified obesity and diabetes as playing a very important role. These are the data sets that have indicated an increased risk of severe disease, hospitalization, and death in people with HIV when comparing them with people without HIV. We have seen data from the US in particular, for example, showing that when looking at the rates of diagnosis, hospitalization, and in-hospital death, people with HIV have an increased rate across these three parameters, and that the risk of severe C19 increases with lowering CD4 cell counts. I will discuss in detail the data from the SARIC cohort, which is a UK-wide cohort. But in summary, day 28 mortality among people hospitalized with C19 is increased by HIV status after adjusting for age, as well as other parameters, including sex, ethnicity, comorbidities, and so forth. There is also another UK-wide study that has taken data from primary care and linked them to the National Death Registry and looked specifically at C19 death in death certificates, and again identified an increased risk of C19 mortality among people with HIV after adjusting for age, sex, ethnicity, deprivation, smoking, and obesity. And finally, we have seen data from the Western Cape in South Africa, data collected from people attending public sector health facilities and indicating that people with HIV have an increased risk of C19 mortality after adjusting for age, sex, and comorbidities. So these data collectively have identified HIV as a risk factor for severe C19 and for an increased risk of mortality. But let's look a bit more in detail at data that take into account gender. There are some very interesting data that come from the New York State analysis. Here we can see that the rates of C19 diagnosis, hospitalization, and in-hospital death when comparing people with and without HIV by gender, first of all, indicate that overall people with HIV have increased rates across all of these three parameters compared with people without HIV. But what is really interesting is that whereas among people without HIV, men tend to have higher rates of diagnosis, hospitalization, and in-hospital death compared to women, the opposite is true when we look at the relationship between gender and outcomes among people with HIV, where women have increased rates of diagnosis, hospitalization, and in-hospital death. However, when the investigators then performed adjusted analysis, the gender, the sex, actually disappeared as an independent predictor of outcomes, and other predictors emerged as independent. As you can see, for diagnosis of non-white ethnicity, region of residence, CD4 count below 200. For the rate of hospitalization, the adjusted analysis indicated that the predictors were age 40 and above, region of residence, and also being in a CD4 count, not just below 200, but also in the CD4 count strata between 200 and 500. Looking specifically at in-hospital death, age was the sole independent parameter. As I mentioned, I will describe in more detail the data from the SARIC CCP UK study. This is a UK-wide study that looked at adults hospitalized with C19 in hospitals across England, Scotland, and Wales. The population included nearly 44,000 people, and of these, 122 were identified as having a confirmed HIV status. And of these, 112 of 122, so 92%, had a record of being on antiretroviral therapy in the study file. The outcomes of this subset of HIV positive people was compared with the outcome was compared with that of people that did not have recognized HIV positivity. People with missing HIV status or unconfirmed positive HIV status were excluded. Comparing the demographic characteristics of people with and without HIV, we see that there were fewer females in the population with HIV, 34% versus 43%. The other important observation, however, was that the median age was significantly lower among people with HIV, median 56 years, compared to people without HIV, median 74 years. Another important observation is that in the population with HIV, there was a larger number of people of Black ethnicity. If we compare the characteristics of women and men with HIV, 42 and 80 respectively, one interesting observation is that the majority of women in this study, 66%, were of Black ethnicity, whereas the majority of men, 60%, were of white ethnicity. Looking at comorbidities, people with HIV had a lower prevalence of chronic heart disease and chronic pulmonary disease, probably reflecting the younger age relative to people without HIV. But there was more obesity among people with HIV, 17% versus 11%, and also more moderate or severe liver disease at 5% versus around 2%. Comparing women and men with HIV indicated that obesity was more common among women, 30%, relative to men with HIV at around 10%. Looking now at the presenting symptoms and signs, what we saw comparing people with and without HIV was that people with HIV had more systemic symptoms, more frequently reported the fever and myalgia, and it was especially common among women with HIV. There were also more respiratory symptoms among people with HIV, with more cough and more chest pain and more sore throat. And there was also an increased prevalence of diarrhea at the time of initial presentation. In terms of signs, among people with HIV, fever and tachycardia were observed more commonly. But as you can see, both the presence of hypoxia at the time of initial presentation and the presence of chest X-ray infiltrates were similar in the two populations. When looking at the lab parameters, there were some important differences between the two groups, but I just would like to point to the lymphocyte count, which was in fact higher among people with HIV compared to people without HIV. And people with HIV also had a lymphopenia recorded at the time of initial presentation less commonly, 47%, than among people without HIV at 58%. Also consistent with the greater prevalence of systemic symptoms, people with HIV had higher C-reactive protein levels. In terms of C19 outcomes, the primary endpoint of the analysis was day 28 mortality. And what we found was that when we looked at the cumulative incidence in the population, comparing people with to people without HIV, the cumulative incidence of day 28 mortality was 27% versus 32%. And importantly, as we can see from the Kaplan-Meier curves, there was no difference between women and when comparing women and when comparing men with and without HIV in terms of day 28 mortality. But a significant and quite marked difference appeared when we compared the outcome, the day 28 mortality, by age group. In particular, people with HIV that were aged below 60 years had a marked increase in the risk of day 28 mortality. In particular, the day 28 mortality in those below 60 years was 21.3% in people with HIV versus 9.6% in people without HIV. We also ran a Cox proportional hazards models in order to understand the relationship between the different variables and day 28 mortality. And whereas in the unadjusted analysis, there was no difference in the two groups when comparing people with and people without HIV, and whereas also we did not see a change in the relationship when we adjusted for sex or ethnicity, we did see a significant change in the relationship when we adjusted for age, where the hazard ratio indicated an increased risk of day 28 mortality in people with HIV. And this relationship didn't really change when we adjusted for both age and sex, when we added ethnicity and other variables, including 10 individual comorbidities that were analyzed. And these included also diabetes and obesity, among others. There was also no significant change when we accounted for the severity of disease at presentation. And when we restricted the analysis, the adjusted analysis to people aged below 60, we found that people with HIV had almost a threefold increase in the risk of day 28 mortality. If we then want to look a bit more in detail at the differences between people with HIV according to the day 28 outcome, looking at those who died versus those that were alive at this time point, we saw no difference when we looked at gender, but we did see some interesting differences. And particularly we saw that obesity and diabetes were more common, more prevalent in those who died. And consistent with this, we also saw that at the time of initial presentation, the median glucose levels and also the prevalence of hyperglycemia were more common among those who died. So in summary, what we saw in this UK study was that at day 28, mortality was higher among people with HIV after adjusting for age. And also we saw that the largest difference was among people aged below 60 years. We also saw this interesting correlation, if you like, or at least an indication of an association between being a bit older with HIV and having obesity or diabetes as being factors that really appear to modulate the risk of mortality. I also should mention that people who died with HIV were less likely to have a record of antiretroviral therapy in their study file. But this study did not have access to the ART history, the CD4 count, or the viral load, which are obviously important limitations. Coming back to the issue of women and HIV and C19, as I've shown you, mortality risk did not differ by gender. However, it's important to appreciate that obesity was more prevalent among women with HIV, and also women were more likely to be of Black ethnicity. And this may place them in a more vulnerable, if you like, scenario in terms of C19 risks. There are some important uncertainties. Of course, we need firmer data on how current and nadir CD4 cell count, ART history, HIV RNA load modulate the risk of severe 19. This is true certainly for the SAREC study, but it's also true for all the available evidence to date. We also need to understand a bit better the role of ART in modulating incidence and severity of SARS-CoV-2 infection. Other points of interest, we know that lymphopenia occurs commonly in people with C19. We don't know what that means in terms of clinical significance for people with HIV. And there is a recommendation that one should monitor the CD4 count if patients with HIV are hospitalized due to C19, and ensure that prophylaxis is started if recommended thresholds are met. We also need to study the incidence and the features of long C19, of the long-lasting symptoms after recovery from the acute phase among people with HIV, and look at the potential for immunoescape if SARS-CoV-2 infection occurs in the context of significant immunosuppression. But definitely we need more gender stratified analysis in order to understand the difference between women and men with HIV in terms of all parameters related to C19, as well as parameters related to vaccination against the virus, including vaccine acceptance, vaccine safety, and efficacy. And what about the management focus? I think at the moment we can certainly say that the management of C19 in people with HIV should be the same as in patients without HIV. HIV status is not a reason to exclude patients from interventions or clinical trials. And if patients are hospitalized because of C19, there should be a careful attention, if you like, paid to the fact that ART should be continued, concomitant medications should be reviewed, and the potential for drug-drug interaction should be considered. At present, we do not recommend that our regimens are changed in order to reduce risk of infection with the SARS-CoV-2 virus or following a diagnosis of C19. For both men and women, I think the data indicated that it's paramount to optimize ART, optimize control of comorbidities, paying specific attention to obesity and diabetes, and obviously provide vaccination and also appropriate counseling on risk. But I would like to conclude my presentation really by also reminding ourselves that many women with HIV are especially vulnerable to the economic and social impact of the pandemic. Thank you.